Welcome back to MLT 130. This is part 2 of the carbohydrates lecture. In the previous lecture, we talked about type 1 and type 2 diabetes mellitus, but we talked about there's 4 different types of diabetes mellitus in total. So the next type that we're going to talk about, or next category, is the other specific types. And these are where hypoglycemia is related to secondary conditions. And there's several conditions that patients may have that cause diabetes secondary to the condition. So these are conditions that patients have that cause them to also have diabetes. So diabetes as a secondary condition. And if you turn to page 187 in your textbook, there is a box 7.5, that will show you all 4 types of diabetes mellitus. And under other specific type, it'll show you different conditions that can cause diabetes secondary to other conditions. So I highly recommend that you open up your textbook and look at some of those conditions. Some examples are genetic defects, diseases of the pancreas, drug or chemical induced conditions, genetic syndromes, things like that. So make sure that you open up your textbook and look at that chart. Again, these are conditions that usually affect the pancreas, endocrine conditions, they're drug or chemical induced. Those are some of the primary categories that cause other specific types of diabetes mellitus. You may be asked some specific conditions on exam 1 that you need to know that causes hypoglycemia that are secondary to the condition. And those would be those that are in that third category. There's another scenario which could cause a short-term hypoglycemic event. So if you think about it, if a patient has had an event of trauma, such as a heart attack, a bad infection, or maybe even an accident, there will be an increase in blood glucose because the body is going to increase or secrete epinephrine. Remember in part 1 of the carbohydrate lecture when we talked about hormones and what epinephrine does. Remember, epinephrine is an insulin antagonist, thus the plasma glucose will increase when epinephrine is involved because it's the fight or flight hormone. Because that person or patient is in the event of a trauma, there is going to be an increase in the glucose, so the patient is going to be in a hypoglycemic event, but once the trauma is resolved, the glucose should return to normal. So that's just kind of a think about it situation where they could be a short-term hypoglycemic event. The last category that we're going to talk about for diabetes mellitus is GDM, or gestational diabetes. And this is when a mom is diagnosed with abnormal glucose and it's found for the first time during pregnancy. Glucose usually returns to normal after the pregnancy, but patients will have an increased risk of diabetes later in life. This usually causes complications with the infant as a result of severe hypoglycemia or low glucose after the cord is cut. This is because the baby in the uterus has been receiving an increase of glucose from the mother's plasma. Thus, the baby produces more insulin in response to maintaining their glucose. And once born, the cord is cut and the baby still has a higher insulin, but the mom's increased glucose supply has been cut off. So the increased insulin then bottoms out in the newborn baby. Usually these babies are typically larger in size that are delivered from our gestational diabetes moms. Women that are pregnant at 25 years of age and older are usually screened at 24 to 28 weeks of gestation for gestational diabetes. We have a few different categories or criteria for diagnosing diabetes mellitus, and these are set up by the American Diabetic Association, or the ADA. And the tests that are usually used are the fasting glucose test, the hemoglobin A1C, the 2-hour post-load glucose, and the random glucose. We categorize diabetes mellitus into 3 categories. Either the patient is normal, the patient is impaired glucose, which is a pre-diabetic, or the patient is diabetic. So of the tests used to determine if a person is diabetic, these criteria have to be met, or these values have to be met to be considered diabetic. For the hemoglobin A1C, it has to be greater or equal to 6.5%. That's the value. For the fasting blood glucose, this is a fast for at least 8 hours, and it has to be greater or equal to 126 milligrams per deciliter. For the 2-hour post-load glucose, it has to be greater or equal to 200 milligrams per deciliter. For the random glucose test, it has to be greater or equal to 200 milligrams per deciliter, and the patient has to also have diabetes mellitus symptoms. So for patients that end up in that pre-diabetic status or impaired status, we're often able to detect if that patient has the potential of being diagnosed for type 2. If you see the glucose results indicate impaired glucose, but not high enough to be actually diagnosed with diabetes mellitus, the patient may be able to change their lifestyle and diet to prevent them from becoming a fully diabetic person or diagnosed with diabetes mellitus type 2. So if you look here, we're talking about people in this middle category for the fasting blood glucose, FBG, it's fasting blood glucose. We're talking about these people that are in this impaired or pre-diabetic stage. So if you have a patient that their result is between 100 and 125, they may be able to change their lifestyle, change their diet, and improve their results before they're actually categorized as a diabetic. For the 2-hour post-load glucose test, it would be those people that fall within 140 to 199. They haven't got up to the 200 yet and are diagnosed as fully diabetic. Again, these are your type 2 diabetic. This wouldn't be your type 1 people. So let's look at a case study, and it would be probably helpful to first look at page 184 in your textbook. There's a box or table, page 7-7, that's got the different categories for diagnosis of pre-diabetics and diabetics that might help you out with this case study. But we have a 59-year-old male that has the following lab results on his annual checkup. And we're going to try to determine if this patient, based on the results, is a normal patient, a pre-diabetic patient, or a diabetic patient. So this patient has a fasting glucose of 123. The doctor ordered a confirmatory test, and it gave the following results. It gave a fasting glucose. The second one is 117, and the 2-hour post-load glucose is 160. So you can look at your chart on page 184 in your textbook to help you answer the question. I would pause the video at this time to try to figure this case study out on your own before you continue on and get the correct answer. The correct answer is this patient is pre-diabetic because the normal fasting glucose should be less than 100. The pre-diabetic is 100 to 125, and of course the diabetic patient would be over 126. For the 2-hour post-load glucose. The normal patient would be less than 140. The pre-diabetic patient would be within the range of 140 to 199. And then the diabetic patient would be 200. So again, the answer to this case study would be the 59-year-old male would be a pre-diabetic patient. So up to this point, we've been talking about hyperglycemia, but now let's switch gears and talk about hypoglycemia. So hypoglycemia is low glucose or plasma glucose, and it usually is defined by below 50 milligrams per deciliter in men and below 45 milligrams per deciliter in women. Symptoms can include things like hunger, sweating, nausea, vomiting, dizziness, shaking, even problems with sight and speech, and even mental confusion. We have a method to help diagnose hypoglycemia. It's called the Whipple triad, and it's 3 factors that's used to help diagnose hypoglycemia. The first is the signs and symptoms of hypoglycemia are being shown. Also, there's documentation of the patient has symptoms at the same time that the plasma glucose is low. And then, of course, the third and final factor is there's alleviation of symptoms of hypoglycemia with the ingestion of glucose. You can have inborn errors in carbohydrate metabolism. We can have glycogen storage diseases. There's 4 that we're going to discuss. It causes a genetic defect that causes the lack of an enzyme needed in the glycogen metabolic system. Thus, we end up with severe hypoglycemia. Remember, our glycogen is primarily stored in the liver and then is converted to glucose for energy. And if this process does not work due to the lack of enzyme, patients will end up with low plasma glucose. So the first in the glycogen storage diseases is type 1 G6PD. This is severe hypoglycemia and is the most common form in the glycogen storage diseases, and it affects the last step of glycogenolysis. Thus, patients cannot convert glycogen to glucose. Then there's type 2, which is Pompe's disease. This is an acid maltase deficiency. Infants and juveniles usually have this form. There's no cure, although treatments can extend the lifetime of the patient. Continuing on in our inborn errors, type 3 is Cory's disease. This is a glycogen debrancher enzyme deficiency. This enzyme is an enzyme that plays a vital role in converting glycogen to glucose. Then type 4, Anderson disease, is also caused by a glycogen brancher enzyme deficiency, and it leads to organ damage. And these patients develop liver cirrhosis by the ages of 3 to 5, and the patient usually dies as a result of chronic liver failure. Another inborn error of metabolism is galactosemia, and it involves the lack of an enzyme which prevents the breakdown of galactose. It's an inherited autosomal recessive trait. Galactosemia can be life-threatening during the newborn period. Because galactosemia is such a problem for newborns, galactosemia is part of newborn screening testing that's required. It's usually required in all states for newborns. Galactose is a major monosaccharide formed from the breakdown of lactose found in milk. So without the enzyme needed for its breakdown, galactose cannot be utilized and it is excreted in the infant's urine. Galactose in large amounts causes failure to thrive in these patients. It causes jaundice and diarrhea, which is dangerous in infants. It also causes hepatic dysfunction and brain edema. Therefore, there is mandatory screening, like I said before, the newborn screening tests for all newborns. And these tests are usually a blood test, and we get the blood from heel sticks in infants usually. We also screen urine which is called a clinic test, which can be done in kids 3 and under, and it's recommended for galactose screening. However, most labs no longer routinely perform or is only 1 and under the age. The newborn screening and symptoms usually diagnose galactosemia earlier. Again, that's the heel stick for the newborn screening. The clinic test screens for the presence of reducing sugars, thus detecting galactose in urine. All right, let's discuss specimen collection for glucose. For the specimen, glucose can be measured from serum or plasma or whole blood. So whole blood values, just something to note, will usually be about 15% lower than plasma or serum samples. Serum and plasma must be refrigerated and separated within 1 hour of collection to prevent cellular use of glucose or glycolysis. So the red cells will metabolize the glucose for energy, or ATP, via glycolysis. Thus, we get a false decrease glucose result. We can prevent glycolysis by collecting the specimen into a gray top tube, which contain the anticoagulant sodium fluoride. If the specimen, it will be delayed in reaching the lab for analysis. So again, sodium fluoride, the anticoagulant, can help prevent glycolysis. There are 2 methodologies commonly used to test for glucose. One is dextrose kinase and the other is glucose oxidase. These are both enzymes. Glucose oxidase is highly specific for D-glucose or dextrose glucose. The advantage is it's a lower cost. The disadvantage is that there are interfering substances such as uric acid, ascorbic acid, and others that can inhibit reactions and results in can be false or lower glucose. Strong oxidizing substances such as bleach can cause false increase in the glucose. But with dextrose kinase, this is the reference method for glucose because it's more specific. But the disadvantage is this enzyme or this test is more expensive. For a patient that has been fasting or has not had anything to eat, the fasting blood glucose level should be between 70 and 99 milligrams per deciliter. We usually use a random glucose level, which the normal would be between 70 and 120, but random glucose levels are affected by food intake, so to screen for diabetes, we should be using a fasting glucose. A patient should fast up to at least 8 hours, but not greater than 16 hours. Even in normal patients, 30 minutes after food, you will see a glucose increase, but it should be back to normal within 2 hours after eating. You can also measure glucose in urine and spinal fluid specimens, or cerebral spinal fluid specimens, CSF. Urine glucose can be measured on a reagent strip in a semi-quantitative method using a 1 to 4 plus method. Something to remember about glucose in urine is that patients will not excrete glucose in urine until their blood glucose has reached the renal threshold of 160 to 180 milligrams per deciliter, and then you will start to see the glucose in the urine. For the CSF glucose or the cerebral spinal fluid glucose, it's done a lot of times when a patient has had a spinal tap to detect meningitis. The CSF glucose is about 2/3 or 60 to 70% of the patient's plasma glucose. So that's something important to remember and make note of. Thus, in a normal patient, the range is only 50 to 80 milligrams per deciliter for the cerebral spinal fluid glucose. It's really important or recommended to draw a plasma glucose about the same time as the spinal fluid glucose is drawn, because the serum or plasma glucose, if it's high or low, it will affect the expected cerebral spinal fluid glucose normal range. Okay, so make sure that both are being drawn about the same time. The plasma glucose sample and the cerebral spinal fluid sample, because the plasma glucose range is going to affect the normal range for the cerebral spinal fluid for the glucose. So why is it important to do a CSF glucose if they're checking for meningitis in a spinal tap? If bacteria, fungi are present in the CSF fluid, then you will see a lower than normal CSF glucose, because the bacteria or fungi is metabolizing the glucose of the CSF. Thus, the meningitis could be missed if the patient has plasma serum glucose not in normal range. So here's just a trivia question to go along with what we just learned. If a patient's serum glucose is 85 milligrams per deciliter, what would you expect the cerebral spinal fluid glucose to read? Pause the video at this time before you go on and find out what the answer is. Have you answered it on your own? If you have, you should have got D, 60 milligrams per deciliter for the cerebral spinal fluid. In addition to fasting and random glucose, we can also do the 2-hour post-load test. It's also known as a postprandial or PP glucose test. It is performed 2 hours after a meal, but a standard glucose drink of 75 milligrams can also be given instead of a meal. The patient drinks the drink, and then a glucose is drawn 2 hours after the drink or meal. In a non-diabetic patient, the glucose should return to normal after 2 hours after the drink or meal. So it is good practice to draw a fasting glucose before giving the drink. If the glucose is already high, such as above 200, it's not a good idea to go ahead and give the drink to make the glucose go higher. A fasting glucose, a high fasting glucose is already diagnostic of diabetes mellitus. A 2-hour postprandial or post-load test over 200 is indicative of diabetes mellitus. Another glucose test is the oral glucose tolerance test. This one is no longer used or recommended by the ADA, but the test procedure is the patient fasts for 10 to 16 hours, so it's usually performed in the morning. The fasting blood glucose is drawn, and they measure the fasting blood glucose, and then the drink is given if the glucose is not already high, and then the patient finishes the drink, and then a glucose level is drawn at the following intervals: a half an hour, 1 hour, 2 hours, and 3 hours. Another test we can use is our hemoglobin A1C. Our red blood cells normally live about 120 days, so the hemoglobin A1C test is indicative of a patient's long-term glucose status over 2 to 3 months. It's used to measure compliance with a diabetic glucose therapy and how well the diabetic patient is keeping their glucose levels in control. The specimen for the hemoglobin A1C test is a EDTA whole blood sample. So the question is, does the specimen for an A1C sample need to be a fasting sample? The answer is no, because this is a reflection of an average glucose over a 2 to 3 month period. The preferred method for testing for the A1C is affinity chromatography, because this method is not dependent, or is not temperature dependent, nor affected by the presence of other types of hemoglobin, such as hemoglobin F, hemoglobin S, or hemoglobin C. Non-diabetic ranges for A1C is between 4 and 6%. Diabetics should be kept under 8% for their A1C. If greater than 8%, the diabetics are not maintaining a good glucose level over that 2 to 3 month period, so meds and diet may need to be adjusted. But something you need to think about with your A1C test is the A1C are based on normal ranges of patients that have red blood cells live in the normal 120-day lifespan. But what if a patient has a condition in which the red blood cells lifespan is shortened, such as hemolytic anemia and hemoglobinopathies, where the red blood cells are not making it to that 120 days? The answer in general is a shorter red blood cell lifespan would yield lower levels of A1C. Microalbumin is a test that can be performed to detect renal disease earlier on. If there is damage to the glomerulus, we will see microalbumin excreted in the urine. Microalbumin will be positive and will be detected before the protein albumin on the urinalysis reagent strip. Here's another trivia question. Which test may be performed to assess the average blood glucose level maintained by a patient over a 2 to 3 month time frame? Pause the video at this time and try to answer it on your own before you will go on to get the answer. The correct answer is C. Ketones is the last topic we're going to discuss. Ketones are the intermediate breakdown products of fat metabolism. We have ketone anemia, which is the presence of ketones in blood that cause breath to have a fruity odor. And if patients have ketones in the blood, they also have ketones in their urine. And we've talked about ketosis or diabetic ketoacidosis that earlier on that can occur in a diabetic where glucose is out of control, and it can be life-threatening if the blood pH becomes too low, and especially if it's not corrected. Conditions other than diabetes mellitus that can cause ketosis include starvation, anorexia, glycogen storage diseases, and prolonged vomiting and diarrhea. For testing your ketones, the specimen is either fresh serum or urine. The lid needs to remain on because acetones can evaporate easily from your specimen. There is no testing method to test for all 3 ketone bodies. In the testing, if you have any kind of color change to purple, you're considered to have some type of ketone. We're not able to necessarily determine which ketone body it is, but it is positive for ketones. There is ketones present. This concludes part 2 of our carbohydrates lecture. If you have any questions or need any extra help, don't hesitate to reach out by email or see me during lab time or see me during my office hours.